We're going to cover upper and lower extremity as well as some basic orthopedic examinations for your infant in this lecture. The upper and lower extremity should be part of your basic infant examination and even in your toddler and younger child. Really the biggest things you're going to look for in the upper extremity and lower extremity is going to be inspection of the area. Are the limbs symmetrical? Are you seeing any issues with movement? So you're going to take them through some range of motion. With infants, be careful with this, as newborns tend to be in a flexed position for about the first few months or so, up to about 6 months. So, don't force a child to move their arms through range of motion. Just kind of let them relax and move through very gently. So the main thing is we're looking to see ease of movement. Is it symmetrical? Is one arm moving more than the other? Are they reaching both sides equally? Those are some of the things we're going to evaluate with this upper extremity. We can also look for muscle tone and strength of the upper extremity. You can use your basic resistant muscle testing that you use on adults in kids that can follow directions. Younger than that, some other tips you might use for checking muscle tone might be, how heavy of a weight, how heavy of a toy can the child pick up? Can they do tummy time? And what does that look like? Are they having some weakness in that shoulder girdle when they lift up into tummy time? So there's some other things that you can do to look at how their upper extremity is developing as far as tone goes. Lower extremity, we're going to do very similar to what we did in upper extremity. So we're really going to look for symmetries. We're going to make sure that the legs are moving properly. So we're going to take them through range of motion. We're going to look for any deformities or any other kind of issues that we might see across the lower extremity. One of the other things that you can do is measure to see if both sides are equal. So you can measure the circumference of the leg to make sure that those are the same size. And you can also measure the leg length. So we can look at apparent and true leg length. So apparent would be where one leg is shorter, but they don't lose any bone length. So this is often measured from the belly button to the medial malleoli on that leg. So that would be where there may be some kind of muscle contracture or something of where that's causing the leg to look shorter. The other measurement would be the true leg length discrepancy, and this is where the pelvis is level but one leg is short. And so this is where loss of bone length is actually true. And so causes of this could be some kind of injury to the area, maybe while they were growing, where the leg's just not growing as far as they need to, some kind of infection, bone disease of that rate. So to measure that one, you're going to measure from the ASIS of the pelvis to the medial malleolus. I've already talked about how we're going to use range of motion to evaluate the extremities as well, but we're going to, look for swelling, look for redness, warmth to the areas. These are all going to be important things to note on our examination. In our infants, we're going to always evaluate the hips, and I'm going to walk through some hip examination in orthopedics here in just a minute. Foot abnormalities are common. So we want to make sure that we're evaluating the feet and gait if they're able to walk. And then, of course, you've got your peripheral pulses that you can also check in this examination. I do want to go over some toe in and toe out presentation of kids. It's not uncommon to see some of this, especially in our infants, but as it starts to go through development, we want to make sure that we're really evaluating these kids to make sure that there isn't something else going on. So toe out or out toeing can be caused by a variety of different things. So you could have some kind of external rotation of some sort in infancy. Maybe that's caused by position in utero, some kind of birth trauma, some genetic factor. It could be that. Some kind of subluxation of some sort. So with toe out, it's not uncommon to see maybe an anterior sacrum, like an anterior sacral base presentation, or an internally rotated ilium. So we're going to talk a little bit more about how to assess those and how to correct the restrictions later when we talk about adjusting, but sometimes even our restrictions will show up as different postural abnormalities. So anytime we see some of those findings, we may want to evaluate pelvis and stuff to make sure there's nothing else going on that maybe we can adjust and help. Toe in is going to be a more common presentation that you're going to see. And really it's going to be important that you determine where the issue is coming from. Is it coming from the femur or the hip? Is it coming from the tibia? Or is it coming from the foot? And so when you have these come in, it's going to be important that you evaluate the whole chain reaction. So not just down at the foot because their toes pointed in, but where is it truly coming from? So one of the common causes is femoral anteversion. So this is where the femur sits a little more anterior. Most kids are born with about 40 degrees of femoral anteversion, and so it'll decrease to about 10 to 15% by adolescence. So this changes over time, so you're going to see that this will develop and alter as the child gets older. But it does cause some issue. One of the problems that you might see if the toe in and issues are coming from the hip is that the child might sit in this W position. This W position is not ideal. It can actually cause a lot of stress to the hips, the knees, the ankles, the feet. Other things that this W setting position can cause is a lack of cross-body coordination. So you're not really going to do any of that cross-crawl patterning when they sit in that position. What happens is that when the child sits in that W position is their pelvis and hips get locked into that place to help stabilize, and so they don't have to use their core. They're not going to reach their right arm away from their right sides. They're always going to stay one-sided. So it's not an ideal position to set in. With these kids, you might see integration of primitive reflex issues, which we'll talk about next week. Core development will be weak. You may have low muscle tone with some of these kids, or even some sensory issues. So there can be some underlying things going on with children that do present in that W set. So make sure that if they are presenting there, that again, we're following up with some other questions and that we're evaluating those hips for sure. From the hips, you're going to move down into the tibia. You're going to look at the patella position, is the patella rotated internally, showing some of that internal tibia torsion. We're going to want to make sure that we check that. Not uncommon to see in newborns up to about the age of 4. So a lot of pediatricians won't get too worried about this early on in infancy because it can be a normal presentation. But it's one of those things that I definitely look at and I make note of in my files. And if there is something that we can do to work on this early on, I definitely do. So please evaluate them and please look through that. And then, if the feet are turned inward, that's definitely something that you may see in infancy as well. With any kind of lower extremity abnormality, you're going to want to look for other signs and symptoms. So, I said a lot of these things can be normal development, but, if they're starting to show limp or gait changes or developmental delays, then we kind of cross over into maybe this is a concern and something to evaluate. So always check in on developmental milestones. Are they delayed in sitting, standing, walking? Is it abnormal walking? Is it abnormal crawling? We want to know that. So those would be some signs and symptoms to really look at to see if this is truly a bigger problem than just a normal toe in, toe out presentation that's there. Just a few pictures to show you what some of this might look like. These are pictures of Emery as a small child. We've dealt with a lot of low muscle tone and issues with her extremities since birth, and you can see in the picture on the left, this is her standing up. She is just about a year or so in here, and you can see quite a bit of pronation with her. Her medial malleoli were almost sitting on the ground with her, but she was definitely having trouble standing unsupported, and if you're standing up and you're standing on your medial malleoli, you don't really have a good base of support with that. So that's definitely a problem. This is the second picture is the W setting I wanted to show you. So you'll see a lot of kids that sit like this. Again, make sure you're not dealing with any kind of muscle tone issues, sensory issues, primitive reflex integration problems. And then really make sure you evaluate the extremities on that. So we may have to do some PT, some core rehab, some different things with that. And then you can see as she sits straight-legged, her feet just flop in with that. So there's definitely some instability and some issues happening in the hip there. So I just wanted to show you some real live pictures of what some of these lower extremity abnormalities might look like. I don't have a separate unit on rehab and treatment of some of these things, so I just kind of threw them in to this presentation. And so, you know, if you're dealing with a child that's maybe showing some flat feet or pronation issues, there's a few things that you can do along the way with them. You know, you can look at adjustments, again, looking at spine, pelvis, sacrum, and even into the lower extremity to see if there needs to be anything. Rehab's going to be a big part. So, you know, I've got a few ideas here on this list. So you could look at, you know, massaging the foot with one of those tactile balls. Sometimes just giving a little input to muscles in the bottom of the foot can help kind of wake them up a little bit. Even vibration can help. We could look at, you know, I know you guys have learned in PT about, you know, strengthening the muscles in the foot by, you know, picking up marbles or different things. You can do the same thing with kids. They can either stand or sit with those. We could look at some balance activities with the disc. You know, you can throw in catching a ball for a little more advanced balance work. So you can use some of those stability pads that we've got. A lot of different ways you can work on balance and stuff with kids. Pillow walks or getting just some uneven surfaces barefoot can also help to strengthen the muscles and stuff in the calf and foot. As far as other strengthening exercises, we could look at, you know, glute strengthening, you know, hip extensions, bridges, sidestepping, heel raises. Those can all be beneficial to help strengthen and rehab the feet and the lower extremity of the kids presenting with some pronation, flat feet. If it's significant enough, you may want to refer out to look at possibility of doing some bracing or orthotics. I know that there are some devices out there. So my kids have used what they call a sure step. It's like a orthotic brace that comes up around their ankle and around their bottom of the foot to kind of put them in the position they want to. So when they are trying to stand and walk, their foot's in the proper position. So it's not intended to fix it or you know, cure it, but it can help aid in getting them going through the right motions on top of doing the rehab and the exercises on top of that. So often the orthotic companies will need a referral from their pediatrician. So you may have to co-manage and refer back to pediatrician to have them send over the proper referral note to the orthotic or PT for that. I do want to chat about gait really quick. You know, gait is one of those things as you're watching toddlers and kids walk, you're not going to see a normal gait pattern, what we see in adults, until about the age of 8. So, you know, when I look at gait, I'm looking for big gross motor deficits. So are they dragging a foot? Are they toe walking? Are they clumsy? Are they losing their balance really easy? So are they not extending one leg? So I'm looking at big picture things when it comes to gait. I'm also looking at, you know, is one foot positioned inward or outward versus the other one? So I'm looking at, you know, symmetry and balance that way as well. So I don't get into a lot of the nitty-gritty details of their gait. I look at kind of big picture gait in younger kids and infants. So one of the things I do want to chat about is the toe walker presentation. Often you'll see the toe walking happen kind of in those early stages of gait. This could be just as they're starting to learn. Most of the time it resolves on its own. I've got it here after age 3. You know, if you're starting to see this toe walking happen with like coordination issues, a lot of muscle stiffness, they're real rigid, we're seeing those developmental delays, you need to refer before that. Again, there could be something else going on that they need followed up or evaluated for. So again, look at signs and symptoms and clinical picture of the kid to know if it's just, you know, maybe it's just how they are starting to walk and it's going to resolve, or if they're having some of those other signs and symptoms, especially developmental delays, we want to make sure they're getting evaluated properly for that. A lot of different causes of toe walking. Probably one of the more common ones that you guys have all heard of is toe walking being associated with autism and cerebral palsy and different things. And it can be, but just because a child's presenting with toe walking doesn't make them, diagnosed with that. Again, clinical picture makes a big part in this diagnosis. So, those are common conditions with it. You can also have some sensory integration problems. So there might be a vestibular problem with maybe balance coordination, maybe even a visual issue. So some kids, if they're having trouble with their eyesight or whatever, they might get on their tippy toes to get a different vantage point so they can see better, or some form like that. You might also see them do toe walking because of a tactile issue. Maybe they don't like the way a certain floor feels. So they might walk fine over carpet, but when they hit like linoleum or hardwood, they'll start to toe walk because they don't like the way that feels on their feet. So it also could be, look at sensory integration problems. It could be a habit. We're going to talk in growth and development about what we call containers and different things. And when I talk about containers, I'm talking about exercisers and walkers and jumper things. And if we're putting those children in those too soon, what'll happen, especially if they're not fit in those properly, they'll actually start to put more pressure on their toes instead of their heel, then toe. And so they'll actually start to develop some kind of habit of where they toe off all the time. So when they get ready to actually walk, they've had all that stimulation in those exercisers and walkers of being on their toes. So that's just what they've developed. So we're going to talk more in depth in the growth and development section on those containers and how they can change how the child develops. We can have some balance and coordination issues that cause toe walking, developmental delays, and also as well as low tone. So there's a lot of things related to the toe walking situation. So dig a little deeper when you have that come into your office. I do want to put some of this information in here for you is, if you do have some patients coming in with toe walking issues and you truly think it might be a habit or we've got some just weakness somewhere, whatever it might be, there are some exercises and things that you can do in office and send it home with them. So I'm just giving you a few examples here. Anything that will get that child to put pressure on their heel and then go to toe is beneficial. So, you've got your heel walks or a bear crawl. The down dog yoga pose is great because it makes them really put their heels down on the ground. Walking up a hill can do it. If you guys ever rode on those little scooters in PE class, those are great things to have at home if you've got a kid that's maybe having some issues with gait, because it requires them to actually put their heel down first and then move their toe through to get that scooter to move. So that could be a fun rehab PT exercise that you can do. And maybe even having a scooter in your office, they can go they can ride it down your hallway or whatever, and you can work on that foot positioning as they do that. You can do some wall stretches. You can even work on some passive stretching of their calf if you think that there's some tightness and issues going there. Hips are really important to evaluate on our babies. And we should be doing this on all infants for at least the first year or so. And you'll notice that pediatricians, when the child goes in for their well-child checkups, that they're also evaluating hips as well. One of the things and one of the conditions that we're trying to look at is developmental hip dysplasia. And in order to do that, we have to do some of these orthopedic tests on the babies to check for that and to screen for it. If a child does have developmental dysplasia of the hip, if it is caught early, that child has a much better prognosis and better outcome if we catch it early. So that's one of the reasons why we check hips always on every kid. And we're going to go through a whole unit on hip dysplasia later on. But I do want to just mention some of the tests that you may come across on our exam forms in the clinic, and then things that you want to make sure that are just part of your general examination of the baby. So like I mentioned, we're going to do range of motion for sure of the lower extremity. So that is going to include the hip. But as far as orthopedic tests go, Ortolani and Barlow are the two common tests that we're going to do. And I'm going to go through Barlow here in just a minute. Ortolani is a test that is supposed to reduce the dislocation. So hip dysplasia has a variety of severity. So it can go from just some instability in the hip to a true posterior dislocation of the hip. And so I'm going to show you some videos and things and animations to help guide you through how you can see this. But what will happen is when you're evaluating the baby, you're going to have the baby laying supine on your table. You're going to take your chiropractic index finger along the shaft of their femur, and you're going to really place it kind of on the back part of their greater trochanter, so you can really feel that space. What you're going to do is you're going to then take the baby's hip and knee into a 90-degree angle, and then you're going to abduct the thigh very gently. Do not put a lot of pressure on this. And as you abduct and press up, like towards the ceiling, what'll happen, if it's a true dislocation of the hip, you're going to feel a clunk, like you're putting the femur head back into the socket. That's what it's going to feel like. That would be a true positive for a hip dislocation or hip dysplasia. So that is Ortolani test. Now, I can tell you that that test isn't always going to give a clunk on a child that maybe has one of the more milder cases of a hip dysplasia. So maybe they're just showing with a hip instability. That still may be hip dysplasia, but they're not going to show a true positive clunk. So you got to be careful with that. And when we get to that unit, I'm going to really go over how to evaluate the instability and the true dislocation later on. But I just want you to be familiar with what this orthopedic test is. So this is Ortolani test. Barlow test is going to be the opposite of Ortolani. So you may hear it called reverse Ortolani's test. It's considered the provocative test, or the test that's going to cause the dislocation. So you're going to have the baby in the same position as you do in Ortolani. So you're going to have the baby lying supine, hip and knee are going to be bent to a 90-degree angle. Your chiropractic index finger is still going to be down the shaft of their femur, but this time you're going to adduct the thigh and press down. And when you press down, what you'll feel is that femur head will slip out like it's dislocating out of the socket. So you'll feel it come push posterior on that. So that would be a positive Barlow's test. Another test that you can do to help determine if you do have a dislocated hip is you can flex the child's knees and hips where you have the child's feet on your examination table, and then you're going to look at the level of the height of their knees. So if you have, I've got a picture here in just a minute to show you, but one of the knees will show lower than the other side, and the lower side would be the side of the posterior femur dislocation. That would also be another indication of a hip dysplasia or a hip dislocation. Another thing that you can also evaluate on kids is their skin folds. So you can look at symmetry of the skin folds on their thighs, on the anterior and posterior side of their thigh. You can also look in the inguinal skin fold as well to see if there's any asymmetries there. It doesn't always mean that there's a hip dysplasia or anything with the skin folds being asymmetry or asymmetrical. It's just kind of one of those soft signs. So if you've got something else, you find they've got range of motion issues, and then maybe a positive orthopedic test on some of the other things you've tested, and abnormal or asymmetrical skin folds, then that might help you determine if they have a true dislocation or a hip dysplasia. But if all your other tests show up fine, there's no other symptoms, their range of motion is good, and they just have one of their little fat rolls isn't quite the same, or it's a little off, that does not mean that it's a true sign. Other skin folds you're going to look at, you can also look at the gluteal fold, where their little bottom and their posterior thigh meet. Sometimes you might see a lowering of one of those as well. So, but even those signs can just indicate there's a possibility of a pelvis restriction or subluxation. So sometimes your PI iliums can show a deeper fold on that gluteal region as well. So don't get too worked up about the skin fold. If that's the only thing you're finding, I wouldn't run and go crazy thinking that it's a hip dysplasia if that's all I'm finding. But if I'm getting some of the other signs and symptoms with it, then that might be another clue to what's going on with the child. these are just the images to go along with the information I just presented in the last slide. Your picture on the left and the right are showing the gluteal folds and the skin folds on the legs. And so this is what we're talking about when we're looking at asymmetry. So on the left-hand side, you've got the green lines for the gluteal fold. Those folds are equal. And then you've got the skin folds on the thigh not matching the other side. So those would be some asymmetries there. And then on your far right picture, you've got the lowering of the gluteal fold with that particular patient. Those, again, those signs don't always mean there's a hip dysplasia. It could be even just a PI ilium on that side. Sometimes you'll see with that type of restriction that you'll have a deeper and lower gluteal fold on that side, or even more folds on the skin or on the legs there for a PI ilium. So if they're not showing any other signs and symptoms with range of motion or anything like that, then it's probably just an incidental finding, nothing to be concerned about. But again, if you're putting all the pictures and the evaluation pieces together, then that could also indicate the hip dysplasia if you're seeing the range of motion issues and the other positive signs. Galazzi's sign is in the middle. This is the one where I was telling you where we have the patient's feet on the table and we're looking at the height of the knees. In this case, the lower knee would be the side of involvement. So this would be the side of the posterior dislocation of the femur head, or the hip dysplasia in this case. Trendelenburg's test is another thing that you can do with your weight-bearing patients. So if they're not weight-bearing, this test isn't going to go very well. But what this is often there's some kind of hip abduction or hip abductor weakness. And so this could be a sign of some kind of hip dysplasia, could be a leg Calvé-Pertez disease, or even a slipped capitofemoral epiphysis issue. So this test can go and help you determine if there is some hip weakness or an issue going on with one side versus the other in a few different of our hip conditions. And we're going to talk more in depth in those later in the trimester, but Trendelenburg might be a nice assessment for you when you're dealing with some kids with some hip issues. I also like Patrick Verbrey as a orthopedic test. I think this one gets you a lot of great information on if maybe the child's in pain or range of motion issues with that. So I often include the Patrick Verbrey orthopedic test with some of my kids. This image is just to show you the Trendelenburg sign and when they stand on one leg versus the other, if you do have some hip weakness, what that would look like. So just in case you needed a reminder of what this sign looked like, again, this is for our weight-bearing kids, and it can show you a variety of different hip issues. So I kind of like to see this as part of my standard examination on my weight-bearing kids, just to see if there is any kind of weakness going on in the hip. And neurological testing, I'm going to get into more in-depth discussion of this next week, but I do want to just mention a couple things about neurological testing to you guys. A lot of what we're going to evaluate neurologically is going to come from our observations of our child, as well as our milestone and growth development. So when we get into talking about developmental milestones and, are they talking, are they walking, are they crawling, those are all going to give us a really good insight in how that child is developing neurologically. So those are going to be some great questions to ask to help us determine if everything's okay. We're also going to go through cranial nerve testing next week and primitive reflex testing. And so we're going to get a lot more in depth with this. But one of the things I want to point out to you is Babinski's reflex. This is going to be an examination that you will perform on your infants and kids. This is where you're going to stroke the lateral part of the foot from the heel to the toes. With children up to age 2, you're going to see an extensor response be normal. So what will happen is as you stroke the foot, the big toe is going to extend and the other toes are going to fan out. This is normal up to age 2. You may see some kids start to integrate this before age 2, and that's fine. But after age 2, it should be fully functioning to where they're not having that extensor response. So you guys have learned that extensor response in adults is abnormal. I'm telling you, it's normal up to age 2. So just keep that in mind when you're evaluating kids. And then deep tendon reflexes. These can be a little tricky to test on kids, especially infants, because like I've mentioned, A lot of babies are still in that flexor, that fetal position for the first few months or so. And so to get them to relax, to test these is kind of difficult to do. Whatever you do, don't force them to extend their extremities or relax. Sometimes you just kind of have to move them through some motion to get them to relax. But do your best with these. You may find a more brisk response in your young kids than you do versus in adults. But again, just make sure that it's all equal bilaterally and all symmetrical with that.